Why would an anesthetist intubate a patient who is still awake?
Picture this. A patient is lying on an operating table in a bright, modern OR. The anesthesiologist is standing right at the head of the bed, holding a laryngoscope and a flexible bronchoscope. You know, the camera and tools they use to navigate the airway. But here's the crazy part. The patient is entirely conscious. I mean, they are breathing completely spontaneously, wide awake, just staring up at the ceiling. For this specific patient, hitting them with general anesthesia right off the bat could instantly turn their airway into a life-threatening situation. So, instead of putting them completely to sleep, you actually have to secure their airway while they are still awake. Welcome to this explainer on awake intubation.
So you gotta wonder, right? Why on earth would an anesthesiologist deliberately intubate an awake patient? And maybe more importantly, how do you actually pass a plastic tube down someone's throat without them completely panicking or coughing uncontrollably? Well, we're going to break down exactly how this highly specialized, incredibly controlled procedure actually works. The goal here isn't just to keep the patient awake for the sake of it, but to maintain their oxygenation and ventilation while safely navigating what can be a pretty treacherous anatomical landscape.
To get a solid grasp on all this, here's our roadmap for today's explainer. First, the difficult airway dilemma. Second, the 3 core goals. Third, prep and patient communication. Fourth, execution and the patient experience. And finally, mistakes and rescue plans.
All right, kicking things off with Section 1, the difficult airway dilemma.
Now, in a normal, straightforward airway, inducing general anesthesia is totally routine. You give the meds, the patient goes to sleep, simple. But if you're dealing with a predicted difficult airway, routine induction triggers a sudden loss of muscle tone and a loss of spontaneous breathing. This can cause the airway to obstruct instantly. If mask ventilation or intubation suddenly becomes impossible at this exact moment, you are suddenly plunged into the ultimate nightmare scenario, what we in the medical field call can't intubate, can't oxygenate. It's a massive, true emergency. Awake intubation, on the other hand, bypasses this danger entirely. Spontaneous breathing just continues uninterrupted, and the airway is definitively secured before the patient ever even closes their eyes.
So, when do we actually pull this critical safety net out? We're looking for clinical red flags, those specific scenarios where a difficult airway is highly anticipated. We're talking about things like severe limitations in mouth opening, restricted neck movement, or a well-documented history of a previous difficult intubation. It also applies to patients with head and neck pathology, upper airway masses, severe obstructive issues, or cervical spine concerns where moving the neck is just flat-out dangerous. The key takeaway here is that this decision always stems from a comprehensive airway assessment. You're looking out for that dangerous combo, a difficult airway paired with a high risk of losing ventilation right after induction.
Moving smoothly along to Section 2, the 3 core goals.
A successful awake intubation isn't just about wrestling the tube in. It's a really delicate balancing act of 3 pillars working in perfect tandem. First, you have to maintain oxygenation at all times. Second, you need excellent topicalisation of the airway. And third, you must secure patient cooperation without unnecessarily depressing their ability to breathe on their own. If any single one of these pillars wobbles, the whole procedure is at risk.
Let's zoom in on that second pillar for a second, because it's often the most misunderstood. Topicalisation is basically the application of a local anesthetic to very specific regions of the airway, like the nasal cavity, the oral cavity, tongue, epiglottis, and vocal cords. The goal? To reduce sensation and suppress those natural airway responses, like the gag reflex. Because let's be real, nobody wants that acting up while a tube is being placed. It's a highly targeted numbing process that makes the whole thing tolerable without having to knock the patient unconscious.
And this brings us to a crucial point. Comfort does absolutely not equal deep sedation. This is a massive, massive misconception. A lot of folks assume that to keep a patient comfortable during an invasive procedure, you just need to give them heavy sedation. But in awake airway management, more sedation does not equal more comfort or safety. Too much sedation actually causes airway obstruction, hypoventilation, and a total loss of patient cooperation. Most dangerously, it suppresses the exact spontaneous breathing we are trying so hard to preserve. Sedation is never a substitute for good topicalisation.
Okay, jumping into Section 3, prep and patient communication.
You absolutely cannot just wing an awake intubation. It is a heavily planned, incredibly deliberate strategy. It is for sure not a technique you try to improvise halfway through a crisis. The essential preparation checklist is strict. Before even starting, the entire team has to be on the same page. You need your standard monitors on the patient, you need continuous oxygen delivery, immediate suction must be right there at hand, the difficult airway cart has to be in the room, and all your backup rescue equipment, it has to be ready to roll.
And all this prep builds directly into the human element. Communication is an airway technique. Honestly, this might be my absolute favorite concept in this entire explainer. Patient cooperation is a literal medical necessity here, and you achieve that through calm, crystal clear communication. You have to explain to the patient that their airway will be numbed. You tell them, hey, you might feel some pressure or a weird sensation in your throat, but you reassure them that they will continue breathing easily the whole time. A calm, well-informed patient is vastly easier to intubate than someone who is frightened or panicking. Your words are quite literally a clinical tool.
Next up, Section 4, Execution and Patient Experience, the actual moment of truth.
Once that airway is perfectly prepped and numbed, the operator chooses their technique, often an awake, flexible bronchoscopic intubation or maybe a video laryngoscope, just depending on the patient's specific anatomy. If they use a flexible bronchoscope, the sequence is actually highly elegant. First, the bronchoscope is carefully advanced through the numbed airway, identifying the epiglottis and then the vocal cords. Second, it enters the trachea, where the operator can visually identify those characteristic tracheal rings, which acts as this sort of anatomical GPS confirming, yes, we are in the right pipe. Third, the endotracheal tube is smoothly slid down over the bronchoscope directly into the trachea. And fourth, placement is immediately confirmed.
But what's going on from the patient's perspective? Well, grounded in good clinical science and basic empathy, we know that with proper topical anesthesia, the conscious patient doesn't experience severe pain. If you were the patient, you might feel some pressure, a sense of touch, or just an unusual sensation of something passing in your throat, but you absolutely should not feel severe pain. You might cough a little bit, and honestly, that's totally okay. This is exactly why that prior communication we just talked about is so vital. If they expect to feel the pressure, they won't panic when it happens. Finally, we hit Section 5, Mistakes and Rescue Plans. Because even in the most controlled environments, we have to manage risk.
A highly controlled awake intubation can devolve into a medical emergency pretty quickly if key mistakes are made. This includes excessive sedation, which, as we know, stops spontaneous breathing, or poor topicalisation, causing the patient to gag and completely panic. Inadequate oxygenation during the procedure is another major risk. Making repeated traumatic attempts that cause bleeding and obscure the airway, terrible idea, as is ignoring the patient if they are clearly becoming intolerant. And perhaps the biggest sin of all, starting the procedure without a solid backup plan.
Managing this requires the mindset of a true expert. Awake intubation should never ever turn into a battle of persistence. The safest airway operator isn't the person who stubbornly pushes through when things get rough. It's the person who recognizes when the primary plan is failing, maybe oxygenation is dropping or the patient is distressed, and stops to pivot early. You pause, you reassess, and you move immediately to Plan B or Plan C. Assuming everything goes smoothly, the procedure concludes with absolute certainty. We don't do guesswork here. Step 1, you secure the airway. Step 2, you confirm it, specifically using continuous waveform capnography, which monitors exhaled carbon dioxide to guarantee effective tracheal ventilation. Only then, at Step 3, after the airway is completely secured and rock-solid confirmed, is the patient finally given the medication to induce general anesthesia and safely go to sleep.
So, to wrap up this explainer, let's look at a quick summary of our core principles. Awake intubation is far more than just intubating an awake patient. It is a meticulous, step-by-step strategy. You prepare your equipment and your team. You carefully topicalize the airway rather than relying on deep sedation. You constantly oxygenate. You continually communicate with your patient. And you always have a rescue plan ready to go.
Which leaves us with this final, provocative thought. A difficult airway should be planned before it becomes an emergency. It flips the whole narrative, doesn't it? Awake intubation sounds like a terrifying procedure to a layperson, but in reality, when performed correctly, it is the ultimate medical safety net. By securing the airway before the patient even loses consciousness, you neutralize the danger before it can even begin. So the next time you hear about a medical team facing a complex surgical airway, ask yourself, are they reacting to a terrifying emergency, or are they proactively disarming it while the patient is still perfectly awake?